All right, everybody, show down. Right, it's really. I want to welcome everybody to the first Shark Seminar of 2025. We're a quarter of the way through our new century, and we're all alive and well. And I'm going to ask Dr. Jake Bleasdale here, who's one of our postdocs in T32 training program, to introduce our guest speaker. And appreciate you coming.
Thank you.
Jake?
All right, thank you. All right, so it's my pleasure to introduce you all to Dr. Sarahmona Przybyla. Dr. Przybyla is a clinical associate professor in the Department of Community Health and Health Behavior at the University of Buffalo School of Public Health and Health Professions. She also serves as the assistant dean and director of undergraduate public health programs. As a public health interventionist, Dr. Przybyla specializes in HIV and STI prevention, substance use, and mixed methods research. Her work focuses on primary and secondary prevention of HIV and other STIs, has examined the impact of substance use on sexual risk behaviors, and explores non-medical prescription drug use. Dr. Przybyla completed her PhD and MPH in health behavior and health education from UNC Chapel Hill. In addition, she also has training from the National Institutes of Health as a pre-doctoral fellow in HIV STI prevention at UNC Chapel Hill, and a postdoctoral fellowship in alcohol etiology and treatment from the Research Institute on Addictions at the University of Buffalo. It's also really wonderful to have Sarahmona here today. Sarahmona was my PhD advisor and committee chair, and I've worked with her for the past 8 years almost. So it's really wonderful, full circle moment to have you here at Florida. So please join me in welcoming Dr. Przybyla.
Thank you, and good morning, everybody. The last time Jake and I were together in front of a podium is when I was introducing him for his doctoral dissertation defense. So we're in a very different role reversal now, but nice to see. I wanted to start my talk today by giving you a little bit of perspective about HIV generally and PrEP more specifically in New York State. So do I have any former New York State residents in the room by chance? You, okay. And so I think this is helpful just to give you a little bit of context, because what HIV looks like certainly is context specific and geographically specific. But I think understanding how PrEP works or doesn't work in New York is also really helpful for context and kind of drawing those parallels with still a very populous state here in Florida, but perhaps a different demographic and maybe a little bit of a different motivation or incentive for prevention based on where we live. So I like to use the term where we live matters. And I think this is a good example of that. When we think about injectable PrEP, there's a lot of recent media stories about what or how the HIV prevention landscape is changing with respect to long-acting injectable options to kind of diversify the menu of choices when we think about HIV prevention. And so I just show you this as an example of kind of where we're at more point in time. Just as a reminder for those of you and where we are with respect to injectable PrEP, in January 2021, so about 4 years ago, is when the FDA approved long-acting injectable ART for treating HIV. That same year, the end of the year, December 2021, is when LAI PrEP or long-acting injectable PrEP received FDA approval. And I mentioned this timeline because this is really important when we initiated the studies that I'm going to be talking about today. So the idea, presumably, is that long-acting injectable PrEP really has this potential to make a population level impact when we think about HIV acquisition and how that would be able to change the field in terms of where and how people can prevent HIV infection. This is just more for fun. For those of you who don't know about injectable PrEP, this just kind of gives you an idea of how the prescription would kind of work and kind of play out over time. So if you start at the far left, there's an option to have an oral lead-in. An initial initiation of injections would occur, and that first injection, a month later, second injection, and then this is the opportunity timeline, but how continuation injections look. So I show you this just more as background to understand this is not a daily experience, but rather being able to space out injectable PrEP for individual patients. Okay, so let me talk a little bit about New York State and kind of where we are. In New York State, we've got a wonderful dashboard, an ETE dashboard, Ending the Epidemic dashboard that's organized and kind of operationalized by the New York State Department of Health. One of the beautiful things about this is they have lots of different data points that are specific to the entire state, but also geographic regions. So Buffalo, you may or may not know, is in the western part of the state. I'll give you a little bit of overview of the entire state and then some specific snapshots into the local community where I operate. So here's what HIV incidence looks like in New York State. And I started this timeline with 2014 because this is when we started actually collecting some data at the state level in terms of oral PrEP. And so you see that there's a decline in HIV incidence. And the end of 2023, they say there's about 1,600 new infections happening in New York State across the board. When we think about this, though, in terms of people living with HIV, and I can't speak to what Florida numbers look like, but this is where we are in New York. So it's estimated that about 112,000 New Yorkers are living with HIV. And the good news is that the majority are aware of their status. So when we think about a status neutral approach to a lot of the work that we do, but also the importance of knowing one's status. Collectively, I would argue that New York State does a pretty good job in terms of diagnosis, in terms of people being aware of their status. Let me, though, just transition a bit to talk a little bit about what PrEP use looks like in New York. So you know a little bit about what HIV infections look like in terms of incidence and total prevalence, but let's look at a little bit about tracking our state in terms of this ETE, Ending the Epidemic Initiative. So most recent year which data are available is 2023, and then you can see here that there's about 55,000 PrEP recipients in New York State, which represents about an 11% increase from the previous year. And what you probably also see is just this trend, right? From 2014 through 2023, about a 10-year period, you're seeing an increase. Presumably you all suspect that the reason why we had a little dip here is COVID, right, phenomenon, but then we're in this nice upward trajectory. These are PrEP recipients anywhere in New York State, right? So this is where we are right now in terms of PrEP uptake. And in fact, this particular initiative is one of 3 primary goals that the New York State Department of Health has for ending the epidemic, one of which is increasing access to and initiation in PrEP care. The other 2 relate to diagnosis and treatment. If we were to break this down by a couple of different geographic, sociodemographic trends, I'm going to show you a little bit about sex and race and age. This kind of demonstrates the differences over time between males and females. So perhaps similar to Florida and many other large states, we see that the largest proportion of PrEP recipients are among males. And this trend continues pretty clearly in New York. I want to highlight this point though, right? So you see on the previous slide, majority of PrEP users are male and has been every single point in time the data was collected. But we know that of all New Yorkers who are newly diagnosed with HIV, 1 in 5 are women, right? Only 7% of PrEP users are women. So this is a great example of a difference or disparity that we might see in between males and females with respect to diagnoses and then who's using. And I mentioned that because I think that relates to some of the research studies that I'll be talking about momentarily. This slide's a little bit harder to see because I know there's a lot of slices, but what you see here over time is PrEP use by age. So another interesting phenomenon in New York State. By and large, the trends are pretty similar from one year to the next. But if we look way over here on the far right, where we see the 2023 data, which was just released about 6 weeks ago, you see that the majority of PrEP users are people in their 30s, right? 30 to 39, which is this green bar. Second most is people 40 to 49. Third most is the 25 to 29-year-olds. A much smaller portion among adolescents and young adults, right? But growing, but the majority of our PrEP users are middle-aged, essentially. I think this is also important. This also shows, though, that that doesn't mean that once you hit 50, you don't take PrEP, right? We still have older adults as well who are using PrEP. And I show you this to also get an understanding of kind of what PrEP use looks like from an age perspective. Let's finally look at this by race. So this slide shows you again, those over time, same years. Let's focus our attention here. As you might suspect, most of our PrEP users are Caucasian. The big green bar is what you see there. African Americans are the red bar here. Hispanics are the orange bar. And so by and large, white recipients of PrEP are overwhelmingly the highest percentage over time. And that trend is likely to continue. But I want to show you this. So similar to the data I showed you about race, here's an example with respect to HIV diagnoses and PrEP use between Blacks and whites. So 43% of newly diagnosed HIV cases in New York are African American or Black, but only about 13% of PrEP users are Black. So this is another example of how we want to think about how we market and advertise PrEP use and the importance of clinician perspectives in having engaging in dialogues with respect to PrEP uptake. Before I move to New York, are there any general burning questions? You're like, I can't pause, I just got to get this off my chest. Anybody? No? Okay, I have 3 kids, they often have to intervene and interject. Nope, y'all are good? Okay, good. Okay, so let me give you a perspective for New York State specific to where Buffalo is. So New York's got lots of different parts, just like Florida does. And WNY, or Western New York, essentially is Buffalo and the 8 counties that surround Erie County, which is where Buffalo is. For any of you who are not Buffalo Bills fans, I won't talk to you the rest of the day. I'm just kidding. Bills won yesterday, life is good. But Western New York is different, right? We've got a small city, Buffalo. The overall metropolitan area is about 1 million people. So we're not New York City. I won't pretend that we're New York City. But I want to give you just a flavor of what PrEP use looks in the region with which I do a lot of my work. So when PrEP started in New York, we didn't have a ton of people at all in Western New York, but we've seen this really nice trend. Again, you see a bit of a COVID blip that you see there. But overall, New York, Western New York in particular, does pretty well in terms of PrEP use, proportionate to the rest of the state. The majority of PrEP users, as you would imagine, are in New York City and the Long Island area. But that doesn't mean that other parts of the state don't matter. Sometimes I have to fight a little bit with New York State about how important it is to get data about Western New York. But let me show you briefly some of these sociodemographic characteristics. So just like we saw for the trend state level, most people in Western New York who are using PrEP are men. Just like we saw for the state data, most of the people using PrEP in Western New York are white. Higher proportions who represent African Americans and Hispanic populations. But and similarly, the same would go for, for age, pardon me, this is the age slide. Same big age groups. This is not different from the state. Most are 30 to 39, and then the surrounding age groups right around that. And then again, similar pattern that we see for race. Most people using PrEP in Western New York are Caucasian. So the state, with this initiative that they have and a lot of funding opportunities that they have available through our AIDS Institute, they kind of think about this as a multi-pronged approach when we think about PrEP uptake and prevention, and how important it is with the center of the slide to think about how we need to increase awareness and education. And that falls on lots of people and places' shoulders to be able to achieve that. But then we need to assess what this actually looks like when we roll it out. We can't ignore the fact that this requires, an interaction with a healthcare clinician at some point. And then what are those other really important support services that need to happen? Just because we build it doesn't mean they come. And if you don't really like your doctor, it's hard to have this dialogue. Or if your doctor you feel like isn't really nice to you because of whatever fill in the blank category with which you are, this is difficult, right? So I really like to use this slide to show you that it isn't just about just prescribe the drug, right? If we're ignoring all these other pieces, you're missing the mark. And if you look more closely at the 4 boxes around the slide, you're going to see all the different players and spaces in which we need to think about from a population level lens about how to really make an impact with respect to PrEP. Questions on any of this one that are burning? Yeah, go ahead.
This looks like a drop of only a couple hundred people, but if you go back to the slide where you were showing PrEP uptake in New York, Western New York at the time.
This one?
Looks like there was a drop off between 2021 and 2022 of these people. Is that mean anything?
Yeah, it's probably relatively insignificant. So numbers wise, to your point, it's probably only a couple hundred people. I don't have a direct answer to that, but I'd like to say that this drop off is relatively insignificant because it was relatively minor. It wasn't a precipitous drop. The overall trend line is moving in the right direction. Yeah. Thank you for asking. Yeah. Okay. So let's move then to the research stuff. How does this relate? So just like we're in a CTSI building, am I still in CTSI? Yes. Okay. Buffalo has a CTSI, and they have a lot of funding opportunities for interdisciplinary collaborative work. And so I was awarded a project with lots of other great people here on this slide to do some work exploring long-acting injectable PrEP. And so with this team science approach, I partnered with co-investigators in different schools. So Amy Heckenberg, some of you may know, Amy's in the School of Nursing. I'm not a nurse and I won't pretend to play one, but Amy's perspective, thinking about clinicians' uptake of PrEP was really important for this project. And then Jean Morse, who's been my mentor for 15 plus years, is in our School of Pharmacy. I can spell pharmacoepidemiology, but beyond that, some of the details about how the pharmacokinetics of the drugs work is just not my specialty area as a public health specialist. But Jean is great to be able to really help me understand the pharmaceutical side to PrEP uptake. And so this is a great way for those of you who are thinking about interdisciplinary or multidisciplinary projects, how important it is to bring in people who don't think like you or maybe aren't trained like you, because these two people were incredibly integral in the project. So this is a little bit of background about what this grant proposal looked like. So the importance of clinical and translational work to maximize not only individual benefits with respect to PrEP, but also population level benefits. We're in this really interesting time frame with changing the PrEP landscape, moving from an oral only version to now an injectable version. And how can, based on some of the slides I've shown you, how can PrEP change incidents, right? We've done a lot of behavioral approaches, many of them work, not always. How can we think about how PrEP can change the game when it comes to incidents? And then finally, we know that there are certain people or groups of people who have a shoulder disproportionate burden of HIV, but yet are lower likely to take PrEP. And so how can we think about how the injectable version of the medicine can really change that landscape to address some potential unmet needs that might be there in vulnerable populations and communities? So we had two primary aims with this particular project. First is what are the barriers and the facilitators to the PrEP care continuum? And then how can we take what we learned from this project to provide some recommendations for intervention, right? How do we think about how to accelerate the adoption of PrEP to reduce HIV infection among vulnerable populations, but also recognize that maybe injectable PrEP isn't for everybody, right? And so we need to understand not only who's interested, but who's not and why. And both of those questions are important, which is why we used a mixed methods approach for this project. So the CTSI grant that I received as a whole and used a mixed methods approach. I had 4 different sub-studies. I'm only going to talk about the top 2 for the interest of time, but we did 4 different projects over this time period. So I'm going to start with the provider studies. So hopefully something that you learned from some of those introductory slides are the importance of the clinician in this conversation, right? I can't walk into Wawa, no, what's the name of the Publix? I can't walk into Publix right now, wrong state, sorry, and be like, I want PrEP, let me just grab it off the shelf and I'm just gonna inject myself. That's not how this works, right? So understanding provider, clinician perspectives is really important. And that's how we started this project. Similar to the overall aims of the grant, we wanted to look at, from the provider perspective, what are their barriers and facilitators to implementing long-acting injectable PrEP in their clinics? And then, what are their attitudes and perceptions about this, right? Different people are ready to change sooner than others, right? And so we think about some of the classic health behavior theories that a lot of you study. This is really important when we think about that. We recruited our study participants, again, these are clinicians, from the New York State Department of Health Voluntary PrEP Provider Directory, a terrible long acronym that I simplified for you. So essentially on the left-hand slide, there's this provider directory. You can sort by what type of need you have in terms of a surface, whether it's PrEP or PAP or HIV or HCV. And then once you put in either a particular county or a zip code, it'll spit out some data. So on the far right of the slide, you see a quick snapshot of Buffalo, essentially. I can probably show you, oh, there's Lancaster, right, like few little towns. So this shows you right away, here are all the places in this like 6 zip code region I can get PrEP. And then you can click on one of these. So here's Buffalo Central. You can click on one of these and then say, okay, here's the phone number, here's their website, this is how you get PrEP. This directory also tells me what providers are prescribing. So a great way to know either a particular provider's name, like an OB/GYN, or a PCP, or some type of internist, as well as a particular clinic that has multiple providers. This is a tool that we use to identify the participants for the provider study. So in order to be eligible for this study, you needed to be licensed to prescribe meds in New York State, have experience prescribing PrEP for at least a short period of time, and then the usual other eligibility criteria. We had participants do a web-based survey. So we talked about this earlier in my meeting. The web-based survey that they did first was some basic background questions and then a qualitative interview. They had to be willing to provide their email address because we paid them with an electronic gift card. So Jake and lots of other research assistants on my project conducted semi-structured qualitative interviews right after injectable PrEP got approved, right? So remember, December of the previous year is when it got approved. So this is a really kind of sweet spot to be able to do this project because it was very early on in the change. Self-administered survey, e-gift card, IRB approved study. So let me show you a little bit about who our clinicians were in this provider study. Average age is about 43. Most of them were female, predominantly white. We asked them, what type of provider are you? So we had about almost 2/3 who were nurse practitioners. Physician's assistants were 16%, and the remaining quarter or so were MDs. And then we asked them, well, what's your specialty? Who are you, right? What do you do? Most of them said, I consider myself to be a primary care provider. About a third said I specialize in HIV or infectious disease. And then we had a small portion who were OBGYNs. So we quantitatively asked in this self-administered survey, do you even know, first of all, about injectable ART, right? Because that was kind of an interesting preliminary question. We found that most of them said, yeah, I know what injectable ART is. Cool, and that makes sense because that was approved at the FDA 11 months prior to injectable PrEP. But then we were like, well, what do you know about injectable PrEP? And are you in fact prescribing it yet? And so this slide on the right shows you that breakdown. So we had more than a third of providers who said, I have no idea what injectable PrEP is. We had a good portion, 21%, who said, I'm aware of it. And guess what? I'm actually started prescribing it, which was cool because we're talking about the first 4 months of this thing being approved. And then the remaining 37%, or sorry, 42% said, I'm aware of injectable PrEP, but I'm just not prescribing it yet. Okay, good so far? Okay, so this is an example I talked about earlier when we met about how important it is to get some background knowledge about your population during the self-administered survey before we actually did the interviews. Okay. Let me quickly go through the primary themes that we found from this provider study. 3 of them specifically talked about what providers saw as the challenges to implementing injectable PrEP in their office or in their clinic setting. First, there were speculative concerns from the patient perspective about side effects. The second was how concerned they were about whether or not their patients would actually be compliant with the frequency of visits. And then, as oftentimes happens when you make a change in a clinic setting, what are those practical and logistical considerations that can really be a game changer? I'm going to walk through all 3 of those. I'll also then walk through 2 other themes that talked about what providers saw as the benefits of injectable PrEP relative to oral. Cognitive burden, human error, which we'll talk more about, and then the importance of privacy. Okay, so these are 5 primary themes that came out of the provider study. So theme 1, I'm highlighting some key terms. But this is an example of one provider who said, you just can't stop it. Once it's injected, it's in your body. It's not like a pill where you could just stop taking it. And if you have side effects, you could just stop it. With an injection, you're stuck with it until it wears off. And I think that's a concern. Notice in the theme that I use the phrase speculative concern. This is what providers are speculating that they think patients will think, right? The second illustrative representative quote kind of gets at this too. I think people are still a little bit leery of it being an injection, of how it makes them feel, whatever way that is, because it's in their body and they can't get it out. Once they get this injection, if they don't like how it makes them feel, they're kind of stuck with it until it just wears out. It's new and people just fear the unknown. So these are some speculative concerns from the provider's angle about what they think patients may or may not feel about this, okay? Our second theme related to appointment compliance. So as you likely know, when you are on injectable PrEP, you got to go to the doctor's office more often than you would if you're on the oral version of the medication. So here's an example about how concerned they had with patient compliance with the appointments. I usually work 5 days a week. How would I take an hour off every other month to just go and get a shot somewhere? That seems like a pain, and having to coordinate travel or any plans around that shot with only a week or 2 on the other end of that flexibility, important concern in terms of appointment compliance. This is also kind of a speculative concern based on who they know, what they know about their patient population. Many people have transportation problems to get to the office for the oral PrEP, right? And so now they might no-show, they might lapse on their injectable PrEP versus if they had an oral version where they could just take that daily pill every day in the privacy of their own home. So these are really important in terms of providers kind of weighing the trade-offs, right? How is this going to work for my patients? And what are the concerns that I have because they've got to have more frequent interactions with me physically in the office? And how might that be a challenge? The third theme is, I think, really important about what's this going to look like for our clinic and how will this impact our support staff? So having it as a medical benefit instead of a pharmacy benefit, not being able to just get it at a pharmacy and needing to go through a special buy and bill contract. A lot of this has to do with how New York State rolled out the pre-authorization approval process for injectable PrEP. Is it a pharmacy benefit? Is it a medical benefit? This was a big challenge at this point in time for sure in New York State about how this is going to roll out. The second piece, it's new. It always takes extra time to just be able to get to policies and procedures to figure out how exactly it's going to work. The upfront time commitment is a challenge, and most of us don't have a lot of time to give, right? So from the provider's perspective, these are some of the concerns that they said, if we were to implement this in the clinic, this is the stuff that we need to be thinking about Or for some who've already rolled it out, this is the day-to-day realities of how complicated this is. Yes, we want to support our patients, but at the end of the day, we need to figure out how this is going to actually be boots on the ground implemented and how this affects our policies and our procedures. Those final two things I want to talk about in terms of some of the barriers. So cognitive burden and human error is what we call this fourth theme. I think the ease of not having to worry about having to take a pill every day. You just have to remember to come to the office to get it. So this is clearly seen as an advantage relative to oral PrEP. The real benefit of injectable medications, other than reducing pill burden, is just that it completely removes human error. Just go in and get your shot. You have to think about something every day. Every 8 weeks, you got to do one and only one thing, as opposed to 56 consecutive days, you got to do something. They don't have to think about it every day. All they have to do is make their appointment and then rely on the nurse or the provider or whoever's giving it their shot. It's out of their hands and there's less room for error. So you can see the advantages that are expressed here of injectable PrEP versus oral. And then finally, privacy, right? For a lot of patients that they see, having a pill bottle in your home or on you can be challenging. And so the advantage here with injectable PrEP is the privacy. Patients are having high risk sexual behaviors. I could see them wanting to not have pills out when they have people over or something like that. And the second representative code, if you're taking oral PrEP, then you have this medicine pill bottle in your cabinet. Somebody looks at it. Why are you on Descovy? Why are you on Truvada? Isn't that for HIV, right? People then would Google it. Oh, it's HIV. Why are you on HIV? Are you HIV positive? Right? These concerns are expressed here versus someone who's on injectable PrEP. There is no pill bottle in your house. There is no indicator on your person that you're taking this medicine. And so this importance of privacy and being able to increase that privacy for patients was incredibly important. So the overall conclusions that we drew from this first study is the importance of understanding and really acknowledging what those patient level concerns are. What are your concerns about side effects and how can we talk through and have a dialogue about that? What are your concerns about appointment frequency? If we switch you over to injectable PrEP, we want to make sure you understand how frequently you need to come in for appointments, and is that something that's going to be burdensome or virtual? For the patient level benefits, the importance of convenience as well as privacy. And then these clinic level realities, the practical and logistical considerations are incredibly important. If you're a smaller clinic, or maybe you're a standalone provider who's doing this, it's a lot to add this if you're only going to have a couple or maybe a few injectable PrEP users in your patient population. Versus a larger clinic who has multiple providers who's doing, hundreds of these a month. That's a very, very different reality from a clinic setting. Okay, I'm going to switch gears now and spend some time talking about the parallel project that we did with patients. So for me, I like to do my projects where understanding all the players as much as I can in the work that we do. So hearing what the providers say, great. But at the end of the day, these are the people that are actually getting the injection, not the providers, right? And so getting both of these perspectives, I think, was incredibly important for this project. We had very similar study objectives, just the angle was different. We were interested in what providers thought about this. So understanding both those facilitators and barriers, and then again, the beliefs, attitudes, and then those healthcare decision-making processes to help understand why someone might or might not adopt injectable PrEP. So we didn't use a PrEP provider directory. Instead, we partnered with many of the clinics in the Western New York area that provide a lot of PrEP services. In fact, in New York State, in Western New York, there's really one big player in this project, and that's Evergreen Health. They are the largest, oldest HIV treatment and prevention agency in Buffalo. And right now, about 85 to 90% of all PrEP patients in Buffalo go there. Lots of clinicians, when they hear about a patient wanting PrEP, they're like, go to Evergreen. It's a great, great place, and also a wonderful example of the importance of a university community partnership, which I'm happy to talk about later. The other big player in this also is our county health department, which also services a large portion of our PrEP patients. We use both active and passive recruitment strategies for this project, and the eligibility criteria are listed here. I want to note something on the last slide, bullet on the slide there. We just said, are you currently using PrEP and have you for about the last 30 days or more? We actually didn't expect any injectable PrEP users on this project because we're like, we rolled out this project, FDA approval kind of just happened. All these people should be oral PrEP. Haha, they weren't, but it all worked out in the end, and I'll show you more about that in a moment. Just like the provider study, semi-structured qualitative interviews. We did this essentially right after the provider study ended. We then started the patient study. Self-administered survey that was done prior to the interview online. E-gift card was provided, and IRB approved study. So we had 34 patients in this project. Here's a little bit of a flavoring of who they were. So they were pretty highly educated. Most of them were working full-time, and I know you can't see that, but majority had private health insurance. In terms of their other sociodemographic characteristics, the average age was about 31. We had the youngest participant was 19, the oldest was 57. Majority of which were male, a small portion Hispanic, and then the majority of which were white. And so if you look at this stuff on the left, this is actually pretty representative of what I showed you earlier when I showed you the slide about those demographic characteristics in terms of who uses PrEP. Thank you. Okay, so we had this self-administered survey, and one of the questions that we asked was, were you diagnosed with a sexually transmitted infection in the past year? And what you can see is there's a high number who said yes to chlamydia, gonorrhea, and syphilis in particular. Now, there could be a couple of reasons for that, right? It could be that they're engaging in higher risk behavior. But remember, if you're engaged with PrEP, you're getting screened for these things every time you go to the doctor's office. So I want you to be mindful about what this data is demonstrating. But important to know that this is a great opportunity to address potentially undiagnosed STIs and get people engaged in treatment. The other piece related that's I think important for SHARP is substance use. So we wanted to get a sense of what people reported with respect to a wide variety of substance use. The top three are listed here. So we've got tobacco, alcohol, and marijuana. And then the frequency is listed here. So we actually had, in terms of a frequency, daily marijuana use was higher than alcohol or tobacco, which I think is interesting. Similarly, weekly alcohol use is about half of the sample, much lower for marijuana. But there's many individuals who report no tobacco use and admittedly no marijuana use. But I think this is important to just get a flavor from a behavioral standpoint who our study participants were. Okay. I mentioned earlier the importance of kind of collecting some data before you get to the interview. And we first actually asked patients, just like we did for the provider study, are you even aware of an injectable PrEP and injectable ART? Now, it's not surprising that a smaller percentage said, I have no idea what injectable ART is, because they're people undiagnosed with HIV and they're probably more interested in prevention than they are treatment. But we had a pretty high number who said, yeah, I've heard of this thing called injectable PrEP, right? So this is just an awareness. This isn't a accuracy of knowledge. It's just, have you ever heard of this thing? And we found that almost 3/4 were aware of injectable PrEP, which I think is a good thing, given where we were from the time from which FDA approval. This is what surprised me, at least a little bit, and maybe Jake too. Well, what are you actually using? And we actually found that almost 12% of our sample was already on injectable PrEP. And we're like, who are you? We actually had one patient who I think was the second or third person in all of New York State to start this, because they're just like, I want it now. I don't consider myself a guinea pig. I consider myself to be a leader, and I want to get on this thing. So this surprised us a little bit, but ended up being quite interesting with respect to analyses. This was unexpected though. I just assumed that everybody would be oral PrEP users. So very interesting to be able to get some of the very early initiators with respect to the injectable version of the medication. I think that the easiest way to show this data for these 34 patients is to think about how we categorize them based on where they were kind of in the readiness to change. So as I mentioned earlier, we had 4 people who had already adopted injectable PrEP. And I'll talk a little bit about why they made that transition. The final 3 I've got here as well. So we've got contemplators. These are the people who are like, I'm thinking about it. I don't really know. I need to know a little bit more. Is this right for me? I'm not quite sure. I'll give you some representative quotes to show what that group looked like. Our third category is the information seekers. I never heard of this thing. I want to learn more. Or, I've heard of it, but I don't know enough. It almost looks like you're an intervention in and of itself, providing that injectable information. And then finally, the majority of our sample were like, I'm good with the status quo. I am quite content with my oral PrEP use. I know you got this other option, but I like vanilla and I'm not going to try chocolate because I've always been a vanilla. I like vanilla. Vanilla satisfies my ice cream needs. I'm not going to make that change. And so I think this is really important to understand that just because something new becomes available doesn't mean that everybody wants to change at all or change now. Let me walk you through these 4 groups to give you a better flavor, for lack of a nice word. Apparently I'm hungry. To talk a little bit about these flavors. So we'll start with these first 4 early adopters. All of them expressed challenges taking a daily oral pill. I was not the best with medication when I first started oral PrEP. I was actively using drugs, so I was struggling with adherence, right? I started on injectable PrEP March 2022, very early adopter. was a very seamless transition. I'd rather be on 6 injections a year, basically, than having to take a pill every single day. For this individual, injectable PrEP, obvious choice. Second representative quote, like many other people, I had adherence trouble. So I switched to injectable PrEP really as convenience. Instead of having to take that daily oral pill, I could just get my shot every 2 months. For individuals who are struggling with adherence challenges for a wide variety of reasons, here's a great way to give them another choice, another option, to be able to allow them to work to prevent HIV, but be able to have a choice that better fits where they are in their life. Convenience was a big piece of this, right? And so this is some representative quotes that you see here. I wish I could do all my medications this way. Wouldn't that be convenient? I'd rather go to the office for 15 minutes every 2 months than try to remember to take a pill every day. This last quote I think is really interesting. That was the big thing that attracted me to injectable PrEP. 2 months instead of every single day. I think it's very reasonable for me to get to the doctor every 2 months to get an injection. The appointments so far have been okay. So these early adopters are actually doing it, not just speculating about it. This has been their experience thus far. And I think these are really positive, promising messages that we're getting. Peace of mind was that last big piece for the early adopters. The challenges that they experience with oral PrEP, particularly with adherence, this is a great way for them to just give them that peace of mind, that confidence to just say, I know I'm in a good place. And earlier when I talked to the provider study about the cognitive burden and human error, this essentially is eliminated. The second quote here, just like the mental peace of mind. I work in an STI clinic. I see the new diagnoses often, the heartbreak of seroconverting. It's not just something that alone will keep me on PrEP, but if all else fails, I know I'm protected because I don't have to worry about picking my meds up and having to take this daily oral pill. These are some really, I think, important lessons that we learned from the perspective of these early adopters who had already started injectable PrEP. Let me move to our second category, which is what we call the contemplators. Many of them are really in this kind of exploratory phase, like I want to learn more, I'm not really sure what this is all about, but let me kind of get a better sense of what this is, right? I've heard of this thing, but I don't really know actually how it works or how it would impact my daily life. So this is a first quote here. It's not something I would consider. I haven't done it, so I can't really say whether or not it'd be better for me, but I do like having a lot of information. I don't have a lot of information at the moment. Definitely something I'd like to explore further, to talk to my provider to see what they would think about it. So this important dialogue between the patient and provider is kind of illustrated here. For the second one, I think it's hard to say. I'm in this routine now, right? I'm in on this oral med, right? 4 or 5 years. It's just become part of my daily habit. I don't really have to think about it because it's part of my daily routine. But I'd have to do some homework on my own before completely committed to making the change. So for some people, it's just a matter of weighing their options and those trade-offs between the oral version that they've been on that tends to generally be successful. They're not really expressing any challenges with adherence, but hey, there's this other option. Is this right for me to make that change? The trade-offs really kind of illustrate some of these quotes as well. Kind of see it 2 different ways. Taking 1 less pill and having 1 less thing on my plate seems easier, right? But at the same time, I'm doubling the amount of the time that I have to go to the doctor, right? To take off from work, right? And so this is kind of that trade-off that this individual is expressing here. I think it's much more convenient than oral PrEP, but I think daily has a few advantages, right? That's just something that concerns me with the injectable. You actually have to go to a provider, you think about access. I have to really think more about it before I make this change. And then finally, a big theme with respect to cost and coverage, right? So for many individuals who are on primary health insurance, as I showed in the previous slide, will my insurance cover this, right? I have no problem with my oral PrEP. I've got my meds covered. I have a $0 copay or a $10 a month copay. Is this going to be covered if I were to make the switch? And then convenience, right? So the simplicity, the convenience that comes from making this change was certainly desirable for a lot of the study participants, as illustrated, kind of reflective of what you saw from the provider study. Daily pill burden, right? Not having to remember to take this every single day. This constant protection without having to worry about missed doses. So this theme certainly is illustrated there. A final group that we have is what we call the content oral users. So they are good with the status quo. Many of them have been on oral PrEP for quite some time. So for this person, I don't think it's right for me. I've been on this oral medicine and I haven't missed a dose, right? So why would I make the change? It's not, I'm not interested in this. I'm good with where I am. Second one, again, I've been on this for 4 years. It's part of my daily routine. My pills are literally delivered to my house. So talk about convenience, right? I never have to drive to the pharmacy. I never have to fill a prescription. This is just part of my daily routine. This home delivery is quite helpful. And I've had successes with adherence. Concerns about how often you need to go to the doctor, right? For a lot of these PrEP patients, they're generally healthy and usually younger. So the thought of having to go to the doctor every 2 months is kind of foreign in a sense, right? So the frequency of visits was a challenge, and this echoes what we saw in the provider study as well. I don't really want to have to go to the doctor every 2 months. I don't have to do that with my oral medicine, so making this change just doesn't seem to be the right fit for me. And then that last piece that we found with the oral content users, I don't like needles. I don't like shots. I'm not the biggest fan. That's a big concern, right? So we want to be mindful about understanding where patients are at. And if the fear of the needles phenomenon is real, asking them to consider this might not be something on their menu of options. So in conclusion, we found that a lot of the attitudes and the strategies, plus the healthcare decision-making experiences, weren't universal, right? We found a wide swath of people's perspectives with this. And really understanding how people perceive the benefits with the trade-off of the challenges, I think is incredibly important when we think about implementation in clinic settings. Okay, so lessons learned. For many patients and providers, doing these interviews was actually a form of an intervention, right? So really talking about what injectable prep is, how it works. It was quite helpful to be able to have that dialogue. Many, but not all current oral prep users were just content with where they were and they were going to stay the course. One of the challenges that we experienced though was reaching underserved or vulnerable populations. They were difficult to reach, difficult to recruit. And as you saw that from some of the demographics from our study sample. My references are listed here, my acknowledgements are here. Thank you to all of my great research assistants who helped with this project and my co-investigators as well. And I'm going to quickly give you something that has nothing to do with my talk, but for those of you who are trainees in the room, a couple of things that I've learned in my experience as a public health researcher. Science requires persistence. Sometimes you get frustrated and overwhelmed and it's just a lot. And you just don't know whether you can have this momentum to carry forward, but persistence matters. And so be mindful about that, I think is important. This I'm borrowing from someone else, Scott Galloway, this is not mine. Follow your talent, not your passion. I think we're taught to follow what makes us passionate, but what I find is when students follow their talent, the passion follows. And I would say that's a lesson that I've learned in working with lots of pre-docs and postdocs and undergrads through that path. The following your talent is a suggestion that I would still consider. The final one I think is for students and sometimes faculty as well. We feel like we always have to say yes. When opportunity knocks, pause before you open or close that door. The feeling that we have to make immediate reactions when something happens sometimes leads us to say yes to stuff that we've overcommitted to. And so this would be one piece of advice that I would say. When that opportunity knocks, just pause, think before you say yes. Okay, Buffalo probably looks like the top slides today. It probably does. I want to say that that's my car on the left. It's not, but sometimes I feel like that's what my car looks like. But Buffalo is also a really beautiful place and space. And so I welcome you to visit when the opportunity knocks. Thank you all for a great time together, and I'm welcome for any questions that we've got. Yeah.
So I'm, as I had mentioned today, I'm interested in women's health. So I'd be curious to find out, are there any studies that have sort of explored why the uptake of PrEP amongst women didn't get to one?
Oral PrEP or injectable PrEP or both?
Either of them.
Yeah, I think for sure, right? And I think some of them are universal. So I don't think there's something particular about your gender or your sexual identity that would connect to that. I think a lot of it has to do with, and you saw this in some of the slides where we had many more males utilizing PrEP than females. And I think what we learned in some of the provider studies in particular, when we were talking with OBGYNs, they oftentimes don't see their clinic as a space for prevention. They see themselves as a space for prenatal care, right? Or for just general reproductive and women's health. But they oftentimes don't think about STI or HIV prevention as their purview. And this is where a lot of referrals out would happen. That's often what we find a lot in a lot of our projects, both from our oral PrEP work and our injectable PrEP work, is that a lot of times there's a disconnect of like, that's not my lane. In fact, we have a paper called purview paradox, this idea that medications like pharmaceutical stuff, that's like the infectious disease specialist thing. I'm a primary care doc, I don't do that. I prevent stuff. But then there's the infectious disease docs over here who say, well, no, this is prevention. Yeah, it involves a drug, but like you're in the business of prevention. This actually should be housed in a primary care setting when we're talking about internists or GPs, not categorizing these types of medications as only an infectious disease specialty type of thing. And so I think that's where we need to be thinking about how prevention involves the whole gamut, not just that it's my job or your job, but it's all of our jobs. And I think that will help to kind of change that dialogue. But what we certainly found in our projects is a lot of OBGYNs just didn't see PrEP as part of their responsibilities. And they would make a referral, which is lovely, but that's actually an additional burden on the patient to now schedule a different appointment in a different clinic with a provider that they don't know, and they may or may not follow through with that. Does that answer your question on that one? Yeah. Leanna, your question to that?
Yeah, a similar question. I know you had small sample sizes with the hard to reach populations. But did you get any sense from the few participants that you had of which group they were in, like the contemplators, the ready to change, and how they felt about staying on being on injectable versus staying on oral?
I don't know off the top of my head. About more than half of the sample were content oral users, but remember, all of them had insurance. So New York State actually has a very robust PrEP app program that's been in existence since 2016. And so for uninsured or underinsured individuals to get PrEP in New York State is very robust and affordable and available. And clinics that offer PrEP, when they have a patient who is uninsured or underinsured, it's super easy to fill out the PrEP app application and somebody's on it and it's a zero copay. The bigger issue is just getting them in the door to start, right? So how do we think about, because a place like Evergreen, which you might be familiar with, right? So Evergreen does everything from HCV to adolescent care to substance use treatment. They're everywhere and doing lots of things. And now they're up to, I think, 9 clinics in and around the Buffalo area. So I like that because in many ways they're a one-stop shop. You can go to Evergreen, or see care. And through that dialogue, you realize that there potentially is a potential to start PrEP. And oh, by the way, you've also have some food insecurity issues. Like it's a one-stop shop. And by the way, you can also get your PrEP prescription right there because they've got a pharmacy on site. So I think that's where a lot of times just getting people in the door will help, and having a place like Evergreen be available in lots of different zip codes in different communities. I think it's been a really important game changer for both HIV prevention and treatment in Western New York. There certainly is still the barrier of being, just because we build it doesn't mean they come. And how do we help underserved or vulnerable populations be comfortable walking in the door? I think is half the battle. Is that good on that? Yeah.
Can
we grab that one? Yeah.
2 questions.
Okay.
The first question.
This one, Luana Hobson is the first question.
Okay, comorbid condition regimens. Yeah, okay, so the first question about comorbidities and so I think that's something that at intake, the clinicians or the support staff have to do a very good job of understanding all the other medical history of a patient and figuring out whether PrEP is right for them. And then if having some comorbidities, being able to track and monitor that. The beauty of something like injectable PrEP is you're coming in 8 times a year, right? You've got a lot of visits. And so those abilities to follow up with patients and doing the required blood panels and STI screens are certainly important. The second question will be a first step in bridging the gap in PrEP uptake, this piece about transportation. So Evergreen, the example that I gave, also has a mobile unit. And that I think is a really great example of how just because we have the brick and mortar building and oh, wonderful, we've got all these new sites and spaces, Erie County Department of Health as well has a mobile clinic. And being able to reach out and go into communities to help make that connection has been a big changer. I'm curious to hear what that's like here in Gainesville, but I think that's a big piece of being able to eliminate some of those known barriers like transportation or childcare. But again, the bigger picture about the full story, right? So if someone is struggling with housing insecurity and they're also having challenges with substance use, perhaps probably not in the top of their priority. And so how do we think about being able to do this full kind of wraparound care to be able to support people where they're at? To help make PrEP part of that conversation. Some providers, in fact, said, I've got patients who struggle with substance use, and I actually would much prefer them to be on injectable PrEP because I don't have to worry about the day-to-day medication adherence challenges. But I still need to get them in the door to give them their shot. And so it's kind of a double challenge that they think about. This is where I think mobile units will really help to change how we think about people coming to us versus us proactively going to them. And then this next question, on the patient side, were the interviews conducted exclusively with people who are receiving oral PrEP? So no, so this is the one where we thought that's what it would be because injectable prep had only been out for a few months. We had 4 of those study participants, about 12%, who were already on the injectable version. If we want to reduce disparities, it's also important people who are at risk are not taking prep. But yeah, so this is a really great question. So this is some of the work that we actually did in the study 3 and study 4 that I didn't talk about today. So we did a qualitative interview with medical students and then a quantitative survey with medical students and pharmacy students, because I think part of it is thinking about initiation of prep for naive individuals, people who've never used prep, and that's part of the pie. The other part of the pie is the oral users who might want to make the transition to prep. The other big piece that I didn't mention today, but I think is also important, is the relapsers, right? So people who are on oral prep, who stopped for a whole host of potential reasons, how do we get them to reinitiate? If they discontinued prep because the oral version wasn't working, they might not know that an injectable version is even available. And so one strategy to think about that is to remember that there's different slices that we need to consider. How do we reach prep naive patients to initiate prep the first time? And then how do we think about the oral prep users who might want to change to or injectable, or the other way, right? There could be injectable users who are like, gosh, I thought this was great, this is terrible, I want to go and try oral. And then third is the relapsers, those who have initiated some type of prep use, have discontinued for whatever reason, and now they might consider themselves to be in a season of risk where we want to reinitiate prep for them. How do we kind of think through how to address their needs and challenges? And I think that's important with respect to the disparities question. Yeah. But I think a lot of this in terms of reaching this population, right? This is where I think the university community partnership is so important for us in Buffalo, and I would imagine here, right? So how do we kind of draw that bridge to help the community-based organizations, the health departments, the clinics, the specialty clinics, understand the work that we do and the way that we can help support them. So one of the things that I really pride myself in and try really hard to do every time I do a project is to give back to the clinicians in particular and the agencies with which I'm partnered. So I almost always go and give a talk and show this data to the clinicians. And a lot of them are like, yeah, I get it. This is exactly the stuff I'm thinking about. They also hear things and see things from our research projects that they hadn't considered. There's stuff that patients tell us as the researchers that they might not tell their clinician. So we gained a lot of interesting insights that they hadn't thought about. Relatedly, a lot of the ways that they ask questions is also really important. So some of the data that I showed about past year STI diagnoses and substance use, many of the clinics that we work with have a lot of data on the STI stuff because they have to do those panels. So they have a lot of information in their medical records on that. They actually don't do necessarily a consistent effort on substance use screening. And that's something that was really insightful for them. They say to us, yeah, sometimes the providers make a note in the chart and we can kind of extrapolate some data, but we need to do a better job of screening for alcohol use as well as other substances. And this data has helped us get a better understanding of evidence-based tools that we should be using consistently with our patients, because right now we're not doing that consistently. And we hadn't really thought about how substance use might be kind of the underlying challenge, the root cause of what might be contributing to these adherence challenges with our patients. So that's something that I would encourage you to also think about, is how important it is to give back to the community partners that are helping you do some of those. Yeah, why don't we start in the back of the class and then we'll go forward. Yeah.
All right, I was curious, we touched on this a little bit, but the population you recruited for the patient study was overwhelmingly really well educated, seemed to be high SDS.
Yeah.
And I would expect that some of that would factor into this high health literacy.
Yeah.
And comfort interacting with care providers.
Sure.
So I'm wondering if you or any groups you work with have similar data for people who might be lower SES or who might have less comfort navigating the healthcare system.
Yeah, a really good question, right? Because, right, we had predominantly male, high education, mostly full-time and mostly privately insured, right? So I think that's important to think about in terms of how to best reach all, right? For the purposes of this project, right, as you often know, you have a budget, you have an end, this is how many people you get, you hit data saturation, and then you run out of money to be able to do these things. And this is where I think working with the community agencies can be really helpful. in future work, I think what would be helpful is the way in which we recruit study participants. So for this one, we did both active and passive recruitment. So we had flyers that were digitally up on their TVs where someone would do a screenshot of a QR code, if I remember correctly, and they could get us, right? But that means they have to have a phone to get the QR code, right? Now, many patients do, but not all. The other is thinking about how to best consider how to make the reach, right? So in future projects, I think it'd be helpful for me to think about which support staff might help to facilitate those conversations. So there are, in many of these agencies, there are prep navigators and prep peer educators who I think could also be a helpful conduit to identify a different socio-demographic of patients instead of me, the nerd, being like, hey, be in my study, did you see my flyer, right? Like, I think that's ways where we can make better connections with the support staff and helping to diversify the study sample. And then admittedly, you can admittedly do that straight up, right? Like having exclusion criteria, you're only eligible if your income bracket is this, or thinking about the different slices of sexual gender minorities, for example, or racial groups to be able to really prioritize potentially underserved or more vulnerable populations. And that's where I think building those partnerships with the community agencies will be able to get you there. As a self-disclosed nerd. I guess I can make that too. Okay, there was another hand. Yes.
First, thank you. But I don't work directly with PrEP, I'm more like an alcohol researcher and strong alcohol and HIV. And so to me, it seems like the underlying assumption of PrEP use is that we want you to get on it, stay on as long as possible, if not forever. And I'm wondering about like the potential flexibility of PrEP use.
Yeah.
And if new patients may have mentioned something like that. So I'm thinking of like someone who might say, the next 6 months, I'm very busy at work, I have a lot going on, and I would choose, I would intentionally not like to engage in sexual activity.
Yeah.
And then in that case, are there any negative physiological effects from pausing, whether that's injectable or
Sure.
and then kind of have patients express any interest and more flexibility over,
For sure.
their.
I'm so glad you asked that question. I have 2 minutes, so I can't succinctly answer it in the depth that I would like to.
I'm staying for lunch.
Cool, great. So why don't we actually table that question? Because I think this is really important in thinking about that perception that you just described, how some clinicians might prescribe to the same approach versus how there may be a disconnect with what patients want or patients need.
Yeah.
And then injectable PrEP totally changes the equation when we think about pharmacokinetically what's actually happening in your body and how stopping the meds doesn't mean it's like out of your body today. So that relates to the side effects slide of like, once I take an side effects, I can't just suck the meds out of my body, where a daily oral pill, you can take it. And that pharmacologic tail, which is really important when we think about injectable medications that are long acting. It's a really, really important piece in thinking about initiation and continuation or not of a medication, whether it's oral or injectable. Yeah, but we'll talk more at lunch for sure. Yeah.
All right, well, let's give our seminar speakers. Cool, and it also put in a plug for our Florida Community Provider Research Conference, April 22, 23 in Orlando. We're gonna have a panel of people discussing challenges to implementing PrEP in Florida. And that will include people working at service agencies, but it might include a person who's on PrEP, it might include sort of some thoughts about this. There's also a 6-month injectable PrEP that's been shown in clinical trials in Africa that could be coming. And I think the challenges for women, I know you say stigma a lot. I mean, there's a lot of different potential stigmas for women and risk factors, and I think there's just a lot to learn about this. But again, come to our conference in Orlando to learn more. Go to Buffalo to learn more about cold weather. Unless you want to see.
Football teams, we've got that too.
They do have excellent NFL teams. So thanks again. And if you are in our T32 training program, you get to have lunch with the speaker. So that's a perk. The downside of T32 is you have to take 12 credit hours. So, that's but the advantage is you get free lunch. So thanks again for coming, everybody, and thank you for coming down.
Thank you.
And I'm glad you did. Thanks, you guys online.
Thank you for your help and thank you for the work.